Thank you very much, David. It's a privilege to be here, and I want to echo the words of my previous speakers who have given their thanks to the organisers for inviting us. It truly is an honour to be here. In the next 20 minutes, I'm going to talk about decompensated liver disease as well as patients with chronic kidney disease. So this will be a whirlwind tour. These are my disclosures. So the objectives are that we're going to review treatment for hepatitis C patients with decompensated liver disease as well as those with chronic kidney disease, understand the limitations of treating these individuals. I'm not going to speak very much on the regimens. You've heard from the two previous speakers that we really cannot use protease inhibitors in patients with decompensated liver disease. That's as much as I will say about that. And we cannot really use sofosbuvir-based regimens in those with advanced chronic kidney disease, particularly those with a GFR of less than 30. And then we'll discuss the effects of viral eradication on liver function as well as on renal function. So we know that the goal of hepatitis C treatment is to eradicate hepatitis C, achieve an SVR, and prevent our individual patients from going on to develop the consequences of end-stage liver disease and liver cancer. And that really this treatment should be applied as broadly as possible so that we can enhance the life expectancy of all of our patients. And that we really should not withhold treatment unless a patient has a very limited life expectancy from some other disease that cannot be remediated by the hepatitis C treatment itself, by liver transplantation or some other treatment. Those individuals who do have a shortened life expectancy, such as those with decompensated liver disease, should be typically managed with the aid of an expert, particularly in a liver transplant program. Now, this has been an amazing trip. I've been involved in hepatitis C since 1995, and we have really come a very, very long way in that period of time. And this is reflected very well in the number of patients that are being added to the waiting list for liver transplantation because of hepatitis C. In comparison with the interferon era, where there was a steady increase in the number of individuals being added to the liver transplant waiting list because of hepatitis C, with the introduction of protease inhibitors around 2011, in the United States we saw a reduction of 5% of the number of individuals being added to the liver transplant list per year. And with the advent of DAA therapy, a significant reduction of 32% when compared with interferon era for hepatitis C. And this was most commonly seen in those individuals being added to the waiting list because of decompensated liver cirrhosis, with a smaller percentage reduction in those individuals being added because of liver cancer caused by hepatitis C virus infection. In this study from Spain, you'll see during two different eras, the era between 2008 and 2013, which does encompass a small period of time when we had protease inhibitors, and a second era of 2014 to 2016, there was a reduction in the number of individuals added to the waiting list for liver transplantation from 47% down to 35%. In consequence, there was also significant improvement in the survival of post-transplant patients, overall from 82% up to 91%. And while some of this may be due to better surgical practices and ICU practices, the vast majority of this improvement was driven by the eradication of hepatitis C, where the survival rate at 3 years was 76% and increased up to 91%. And in multivariable analysis, hepatitis C was an independent predictor of this survival. This has come about because of the treatment of hepatitis C in patients with advanced liver disease, decompensated liver disease, as well as those individuals who have had a liver transplant. And this is data from the Astral-4 study that enrolled only patients with Child-Pugh liver cirrhosis. And it randomized them to receive sofosbuvir, valpadosvir for 12 weeks, sofosbuvir, valpadosvir, and ribavirin for 12 weeks, or sofosbuvir and valpadosvir for 24 weeks. And while it was not powered to show a difference between these individual groups, there was a numerical advantage to patients who were treated with sofosbuvir, valpadosvir, and ribavirin, indicating that ribavirin is probably indicated in patients with decompensated liver disease. Most of the other studies, which we'll show in a few minutes, SOLAR-1 and SOLAR-2, also used ribavirin. What was also seen in this study, though, was that there was a significant improvement in liver function, particularly denoted by MELD score in a population of patients that achieved sustained virological response. In those individuals that had an SVR who has started off with a MELD score of greater than 15, 84% of these individuals had an improvement in their MELD score. 8% remained stable, and a further 8% had a worsening of their MELD score. I will point out, though, that the improvements were largely by 1 or 2 points, the vast majority of patients having very modest improvements in MELD score, and more significant improvements in MELD score only seen in a small number of individuals. But this gave sort of some evidence to the theory that we could reverse liver decompensation by eradicating hepatitis C virus. If we take all of the studies that have looked at decompensated liver cirrhosis, SOLAR-1, SOLAR-2, ALLY-1, SEASALT, ASTRAL-4, we come up with about 801 patients who have been treated with a combination of drugs that vary from sofosbuvir and ledipasvir with ribavirin, decladisvir, sofosbuvir, sofosbuvir, valpadisvir, and sofosbuvir, decladisvir. Now, there was a small number of patients, 27, who did receive a protease inhibitor, but really this combination of drugs is not really adequate or ideal, I should say, for individuals with decompensated liver cirrhosis. Now, the SVR rates that we've seen by combining all of these studies are lower than what was previously presented by the two prior speakers, at around 83%. But 60% of these individuals had a clinical improvement in their biological as well as clinical predictors of liver disease. There was about a quarter of these individuals that actually worsened over a period of time. Again, looking at the bottom of the slide, however, you'll see that it's only around 14% of individuals that have a significant improvement in MEL score by 5 or 6 points. With the vast majority of patients, over 50% of individuals only having improvements in MEL score of 1 or 2 points. This is a study using the Early Access Program for the United Kingdom, which really highlighted that the use of sofosbuvir and decladisvir was actually safe in individuals with decompensated liver disease. They had, again, an SVR rate of about 81% in this study. And when they looked at baseline predictors to try and identify which patients with decompensated liver cirrhosis would improve, they showed that there was an improvement by less than 1 MEL point. They found that those individuals that were aged less than 65, or those individuals that had an albumin of greater than, those individuals older than 65, or those individuals with an albumin less than 3.5 were unlikely to derive a clinical benefit. However, these two predictors were not strong enough to determine whether you should or should not treat these individuals. If we just look at patient-reported outcomes in individuals who were treated with decompensated liver cirrhosis, and this is data taken from the ASTRAL-4 study of sofosbuvir, valpadisvir with or without ribavirin, we can see that in almost every patient-reported outcome, there has been a significant improvement at the time point of SVR12 and SVR24 by eradicating virus. There were only 2 patient-reported outcomes that did not improve, and one of those was absenteeism. Individuals who received ribavirin had a slower improvement in their patient-reported outcomes as compared to those individuals that did not, but even those individuals had a significant improvement in outcomes over time. Now, what does all this translate into? This is another Spanish study that looks at individuals who are on a waiting list, and the vast majority of these individuals were on a waiting list because of decompensated liver cirrhosis. And what you can see here is over 80 months, there is about 24% of individuals who were able to be delisted, removed from the waiting list because they improve. This is clinical improvement in liver function that allows these individuals to come off a transplant waiting list. On the right-hand side of the slide, however, you will see that it is really the vast majority of patients that were delisted were patients who had a reduction in their MEL score, and that nobody with a baseline MEL score of over 20 was actually delisted with DAA therapy. Comparing the individuals at the bottom of the slide who were delisted versus those individuals who remained listed, there was no significant difference in gender, age, bilirubin, albumin, INR, or other factors. When the group subsequently did a multivariate analysis to look at specific indicators that resulted, that could predict delisting, a change in MEL score over time was found to be predictive of being able to come off the waiting list. That kind of is intuitive sense. So we decided to look at baseline predictors. Sitting in front of your patient today, are you able to tell your patient with decompensated liver disease whether you can improve their liver function? We can tell them right now that they have about an 85, maybe 90% chance of eradicating the virus, but what will actually happen to their liver function? So we took 4 studies. The smaller study here was a group of patients who were treated with sofosbuvir and ribavirin for 48 weeks to see if we could impact on portal pressure. These were all Child-Pugh B patients. There were some Child-Pugh C patients who entered into the trial, but were not supposed to. And we had the SOLAR-1, SOLAR-2, and ASTRAL-4 patients, all again patients predominantly with Child-B liver cirrhosis. And they received either sofosbuvir, ribavirin for 48 weeks, or sofosbuvir, ledipasvir for 12 or 24, and valpadisvir, sofosbuvir for 12 or 24. Interestingly, the SVR rate in this study again was 85%. A reduction when we compared to compensated patients. There were 2.7% of patients in this cohort that died, and there were 5.6% of patients who died, and 2.7% of patients went on to transplant. Now, you did not have to be a transplant candidate to enter into any of these studies, and unfortunately, one of the limitations of our study is we did not have waitlisting characteristics or a registry of transplantation to correlate these facts. We identified that there were a number of factors that predicted improvement in liver function. Our endpoint was to improve a patient to a Child-Pugh A status. That meant getting rid of their ascites, their encephalopathy, and have an improvement in their biochemical markers of liver disease. African American race, a low BMI, a high ALT were all predictors of achieving a Child-Pugh A status. And not surprisingly, the presence of ascites, encephalopathy, a low albumin, a high bilirubin, and prolonged INR were all indicators that you would not improve. We created a simplified scoring system where we gave patients who had a BMI of less than 25 1 point, in the absence of encephalopathy 1 point, the absence of ascites 1 point, an ALT of greater than 1.5 times the upper limit of normal 1 point, and an albumin of greater than 3.5 1 point. So you can do this math in your head when you're sitting in front of a patient in your clinic, and then you can determine whether this individual is likely to reverse to a Child-Pugh A with eradication of their hepatitis C. And what you'll see here is that individuals who had a B3A score of 4 or 5, that they had a 75% chance of becoming compensated, whereas those individuals with a score of 0 to 1 had a very low chance of developing compensated liver disease after eradication of their hepatitis C. We put this into an online calculator for convenience. This is one example where a patient has a BMI of greater than 35. They do have encephalopathy but no ascites. They have an albumin of 2.8, an ALT of 28, and their B3A score is only 1, and that person has about a 10% chance of developing Child-Pugh A liver disease over time, so reversing from a Child-Pugh C or a Child-Pugh B. Unfortunately, our B3A score was not able to predict liver transplantation or death. SVR was associated with reduction in death or the need for liver transplantation. Having an abnormal ALT of greater than 1.5 was predictive against death or transplantation, indicating that reversal of the inflammatory response with direct antiviral therapy improves liver function. Now, one of the other issues that we tried to address in this study was to determine whether we were doing any harm to our individuals with decompensated liver disease. So if these individuals were all candidates for liver transplant, these are the characteristics here before and after DAA therapy. And what you'll see is we have MEL score on the y-axis and Child-Pugh score on the x-axis. So at the beginning of therapy, everyone has decompensated liver disease, so they have a Child-Pugh score of 7 or higher. But there's a varying degree of MEL scores between 5 and 30. 151 patients started off in what I would consider a transplant zone, zone 3, up in the top right-hand corner, and that is indicated by this red box, indicating that these individuals had a high MEL score, greater than 15, and were decompensated, so therefore they met the criteria for liver transplantation. We were able to reduce this to 63 individuals after DAA therapy. The yellow box, however, denotes this possibility of what we call MELD purgatory. MELD purgatory is where you improve the MEL score to less than 15, therefore hampering your chances of receiving a liver transplant in a MELD allocation system. But you still have decompensated liver disease by evidence of having a Child-Pugh score of greater than 7. So the predictor of being in MELD purgatory was, after DAA therapy, was actually being in MELD purgatory before DAA therapy. That makes sense. But there was a group of individuals that actually transported from the top right-hand corner of this, the red zone, into the yellow zone, and that was about 30% of individuals. When we looked to see were there any baseline predictors of actually ending up in MELD purgatory from being a previous transplant candidate, we could not identify any. So in conclusion, for the treatment of decompensated liver disease, we achieve a sustained virological response rate of about 85%. And about 31% of individuals who have Child-Pugh B or Child-Pugh C decompensated liver cirrhosis can expect an improvement in their liver function so that they may no longer require liver transplantation for decompensated liver disease. There are various cutoffs that have been proposed by various societies. EASL guidance suggests a MEL score of less than 18 to 20 to receive DAA therapy. The ILTS in one of our consensus conferences before we had a whole lot of data suggested that we should not treat individuals with a MEL score of greater than 30, and we should actually transplant them first and treat them later. The Spanish hepatitis C registry suggests a MEL of less than 18 for treatment. Our study would suggest that individuals with a MEL score between 12 and 14, or those greater than 15, had a lower likelihood of deriving a clinical response with odds ratios of 0.69 and 0.34. Predictive models, however, are probably better than just picking an isolated MEL score. Changes in MEL score over treatment don't allow you to predict at the beginning or the onset of treatment. The English study would suggest that anyone over the age of 65 with hypoalbuminemia or hyponatremia might not do well. And the B3A score right now, to our knowledge, is probably the best assessment to determine whether patients reverse their decompensation. So briefly, to turn my attention to chronic kidney disease, we know that there is a very strong association between hepatitis C and chronic kidney disease. On the one hand, hepatitis C is a major cause of chronic kidney disease, particularly MPGN, and that hepatitis C can actually occur as a consequence of the treatments of chronic kidney disease with blood transfusions, nosocomial transmission during dialysis centers, as well as transmission of hepatitis C through kidney grafts. I really don't wish to speak too much on the selection of treatment, but we know that sofosbuvir-based regimens are not cleared very well by individuals with a GFR of less than 30. And the guidelines here is that we should really use glecaprevir, prabintasvir for individuals with a GFR of less than 30, or grazoprevir and elbasvir, or one of the older regimens, ombidisvir, paritaprevir, and with ritonavir and dasaprevir. And the sofosbuvir should really only be used for individuals where there is no alternative, such as those who probably have concomitant decompensated liver disease as well as renal impairment. Now, the data for treating these patients with chronic kidney disease comes from a number of studies. This is the C-SURFER study, and again, just like our previous speakers have shown, a combination of two agents, grazoprevir and elbasvir, has been associated with cure rates of between 99 and 100%, and what you'll see here in the yellow bars is individuals who are treated straight away, and the green bars are those individuals who were in the placebo-controlled arm and subsequently treated later, but the results are pretty much the same. Glecaprevir and prabintasvir are also associated with significant SVRs at SVR12 and SVR24, again with sustained virological response rates higher than 95% in individuals with chronic kidney disease. This translates into real-world data, where you can see here that even those individuals, albeit a small number, with stage 5 chronic kidney disease achieve SVR 100% of the time. And this is regardless of whether these individuals are genotype 1A, 1B, whether they harbor resistance profiles, whether they're treatment naive or treatment experienced, and whether they have advanced fibrosis or F0 to F3. This is the reason why we should not give sofosbuvir to our individuals with chronic kidney disease with a GFR of less than 30. You'll see here that there is an accumulation of sofosbuvir, and this is data from a non-hep C infected individual who has chronic kidney disease. There's an accumulation of sofosbuvir as well as its active metabolite by significant amounts here. These numbers are percentages. They are not a measurement of nanomoles or picomoles. These are percentage increases, and there are significant differences as to whether you give it pre-dialysis or post-dialysis. So essentially, sofosbuvir is not indicated in patients who have a GFR of less than 30. However, if we turn to real-world data, and here you'll see a combination of sofosbuvir used in multiple different regimens. This is a study published from the Target group, which shows that you can achieve SVR rates close to 100% in individuals with GFRs of less than 30, but this is highly variable depending on the combination of agents that you pick. So in the real world, sofosbuvir has been used in carefully selected individuals with caution, but not in clinical trial. So in conclusion, patients with renal failure are a high priority for hepatitis C treatment. Pangenotypic regimens are highly effective and well tolerated in patients with renal failure, and care should be exercised in treating those individuals with end-stage renal failure, particularly those with decompensated liver disease, where you really can't use a protease inhibitor-based regimen because of decompensated liver disease, and we should try and avoid sofosbuvir in individuals with GFRs of less than 30. However, in those select situations, you really have a choice to make, and there is some data in the literature to suggest that you can do it safely. So thank you very much.